Hey guys, Woodruff here. Let's talk about GERD, also known as gastroesophageal reflux disease. Say it 5 times fast. So let's talk about this disorder. This is very common. This is something that you're going to have a lot of patients that have this. It's especially very common related to our diet and lifestyle choices that we have in America. But many people have symptoms of this, even if they don't have the actual disease. They have symptoms of reflux, or they may complain of heartburn. It's definitely something you want to be aware of. So pretty much what's happening with GERD is that there is a sphincter at the top of your stomach known as your lower esophageal sphincter, or LES. And there can be problems with your LES where it's not closing as tightly as it should. And it allows that for the contents that are in your stomach to back up into the esophagus, which can, and it can actually back up all the way into your throat, into your mouth. And you end up getting stomach acid, enzymes, bile, things like that into your esophagus, which can lead to uncomfortable symptoms, but also it can lead to breakdown of your tissues and your esophagus. It can lead to problems with your teeth. It can lead to a lot of complications, aspiration. I could go on. We're going to talk about it. But the problem is that either you're filling up with too many foods and you don't have good motility. You have a problem with that lower esophageal sphincter. And then the big issue here is that you can do a lot of damage to your esophagus. So the people that are more at risk for this are going to be those that have a lot of pressure on their abdomen. So people that are obese and pregnant are going to be high risk. A lot of it also has to do with lifestyle. So things like smoking. Smoking is horrible for the GI system, as it is every system, but causes constriction and flow issues, and can lead to a lot of tissue issues and tissue flow issues. But yes, drinking can cause irritation, poor diet. You're going to find for GIGU, there's certain irritants. And for most of the, especially upper GI stuff that we're going to talk about, the irritants are going to be spicy, fatty, and acidic foods, which we'll talk about more later. Then you also want to think about medications that can trigger or upset the stomach. Things like NSAIDs, oral potassium supplements can also be triggers. Oh, let's try again. So let's talk about this lower esophageal sphincter pressure. So this is a sphincter, just like, you have a sphincter that allows you to keep urine in your bladder so that you're not just peeing constantly, and a sphincter that allows you to keep poop within your anus so that you're not just pooping nonstop. You have this sphincter and it's at the top of your stomach. It's called the lower esophageal sphincter. And this allows for stomach contents to not move backwards. So once you eat something, it helps stuff moving forward or keeps things from moving backwards. So something that's a hard concept maybe to understand is that when I have this less is more thing. So if I have less sphincter pressure, I have more GERD. And what I mean by that is that this is one time where I want more pressure. So when I say more pressure, I'm talking about more closure. So if I have high LES pressure, that's a good thing, because that means my sphincter is closed and food can't move backwards. But if I have low sphincter pressure or sphincter closure, then I have more stuff that can move backwards. So the things that are the common triggers are everything that is good in life. So pretty much if you want to improve GERD, a lot of times the things you have to improve is you have to get rid of all the pleasurable things in life, like alcohol, chocolate, fatty foods, nicotine, caffeine, and a lot of medications can irritate it. So in other words, what I'm saying here is that these irritants cause the sphincter that's at the top of your stomach, preventing stuff from backflowing, to be weak. And you do not want a weak sphincter, because then stuff leaks backwards and can lead to this reflux. Oh, not the chat. All right, sorry. Gotta love Zoom. So we're going to talk about hiatal hernia when we talk about GERD too, because this is actually, it looks just like it. It's a completely different problem, but has the exact same symptoms. So as a result, we're going to talk about it kind of side by side. So we're going to talk more about hernias when we get to lower GI, but a hernia is something that it's a tissue that goes where it doesn't belong. It slips into an area of, like, there's weakened tissue. It's usually in your abdominal cavity, and it's some intestines or other tissue, like for example, hiatal hernia, it's the stomach, it slips into an area it's not supposed to be because the tissue is weak. So with a hiatal hernia, also known as a diaphragmatic hernia, what happens is that the diaphragm usually stands to help to create pressure, like with that lower esophageal sphincter pressure, and it helps to keep things closed. But with a hiatal hernia, there's weakness in that diaphragm. And as you can see in this picture back here, part of the stomach, this part up here at the top is supposed to be below here in the diaphragm. It slips above the diaphragm. So there's nothing to help keep it closed. So what you end up having is a lot of reflux. So the hernia part is that the tissue has slipped, but as a result of the tissue slipping above this diaphragm, now we don't have that good closure at the top of the stomach, and then we end up having more reflux. So hiatal hernia looks just like reflux, even though it's a different process. It's like a different cause. People that are more at risk for this type of hernia are going to be older age, and again, people with obesity, pregnancy, ascites that have more pressure. So for both of these, what are we expecting to find? Patients are going to complain that it burns. Heartburn is also known as pyrosis, which sounds really cool. Like if you had to have a disease, be like, oh man, I got that pyrosis. And I might be saying that really bad too. But I mean, it sounds like fire. So like, it sounds like something cool to have, but it is not something that's fun to have. So patients that have heartburn usually complain of epigastric burning, or it sometimes can even be mistaken for chest pain, which we'll talk about. But a burning in their chest, it usually happens, it coincides with meals. So it usually happens after they eat, a few hours after they eat. They may also complain of regurgitation, and like actually feeling like stuff is moving backwards. They can have what's called dyspepsia, which is a pain or discomfort in their upper abdomen. And then also like to the point where they can have like hot, bitter, or sour liquid in their throat and their mouth, which is that bile and other acid coming up. They can end up having respiratory symptoms. This is not expected, but it can be a sign of a problem where they have difficulty wheezing, coughing, dyspnea, wet lung sounds, things like that. They may even feel a lump in their throat from like food coming backwards, or have a hoarseness from the stomach acids and bile irritating the vocal cord tissue. And then specifically for hernia, what you might hear is bowel sounds in the lungs, which sounds weird, but you have to think about it as normally the diaphragm separates the the bowel sounds from the lung sounds. But when that stomach tissue slips up above the diaphragm, you're listening to the lungs, but you're actually also hearing bowel sounds because of the stomach contents being above that diaphragm. It's the strangest thing at first, but after you're sitting there, because I had a student once that was like, I swear I'm hearing bowel sounds. I think I'm losing my mind. And they thought they were crazy. And I was like, nope. And the patient did have a hernia. So priority assessments are going to be a GI assessment. So that's going to include like looking at contour, looking at how the patient is doing with like symptoms and stuff like that, what discomforts that they're experiencing. And definitely look for any signs of changes to contour sounds, bowel sounds, stuff like that. Then a pain assessment, and kind of you want to get like a very good quality PQRST kind of pain assessment where you're seeing like what happened before. What makes it better or worse? What do you call it? What would you rate it? How would you describe the pain? That's going to definitely help, because with GI stuff, it's tricky because they can have a lot of different pains, and we definitely want to narrow in on, okay, where's this pain coming from? And then respiratory assessment, we want to listen to their lungs. We're mostly looking for complications there, but it's very key to do that. So what's the difference between GERD and angina? This is really important because you can have this where you're in the hospital and a patient's like, I'm having chest pain. And, of course, when you're a new nurse, you're like, oh my God, like I got to do something right now. Go get an EKG. But what you want to do first, you want to kind of assess, like, did they just eat a meal? If they just ate a meal, my first go-to is like, hey, let me get some antacids. And we usually, this is like really the only way we can tell the difference is that if I have a patient who's having chest pain and I give them an antacid and their chest pain doesn't get better, I'm going to be looking into, hey, this is probably angina. Whereas if I give someone who is having chest pain, especially after a meal, and I give them an antacid and they're better, then that's a good sign that they have reflux. A lot of times this is kind of the tricky thing, because I know it seems like we should be testing and getting a bunch of invasive stuff for angina, but you always want to think that even though, angina is super scary, and you have to consider a whole patient picture. Like if I have a patient who's there for chest pain and who had a heart attack, I'm not going to sit there and be like, oh, it's probably reflux. But if I have a patient who just ate, who has a history of reflux, depending on how they're describing the pain too, I usually like to kind of get an idea of what they think it is. Because I mean, especially people that have had both, they can tell the difference. Angina usually is more of like a crushing, sitting on your chest pain, but sitting like an elephant sitting on your chest kind of pain, really heavy for those characteristic symptoms. But GERD is more of like a burning pain, but they can have both. So again, they look the same, but the best way to tell is to start to try to treat one or both. And usually we start with trying to treat the GERD with some antacids, and if their symptoms aren't getting better pretty quickly, then we're going to start treating them on that chest pain protocol. So how do we diagnose this? Most of the time we diagnose it based on symptoms and ruling out other causes, but sometimes we need to do further studies. Like we might want to see if there's any damage to the esophagus going on. So for that, we're going to do an endoscopy, and then we can also do what's called a barium swallow. And this is a test that allows us to see how stuff is being processed, if it's moving forward, the motility stuff. We can also do manometry, which is, it can tell us how strong that lower esophageal sphincter pressure is. So let's do a practice question. It says, which statement by the client would indicate they are experiencing a complication of GERD and hiatal hernia? So let's look through these. The first one is, my dentist says I need 3 fillings next month. We did talk about there being teeth issues related to GERD, so that sounds possible. Let's keep going. I get headaches intermittently throughout the day. Well, headaches could be a variety of causes and stuff like that, like we talked about in the last section. I don't necessarily know if there's a connection between headaches and GERD hiatal hernia. All right, the next one, C. It's been harder to breathe through my nose lately. So I definitely like that first part of the sentence. It's been harder to breathe. That kind of like ding, ding, ding. I'm like, ooh, aspiration. But it says through my nose. So this is really saying, like, does GERD or hiatal hernia cause inflammation in the nose or more mucus or something else? And I don't really think it causes that, or that's not going to be something that's very common. I have burning with urination and have been going more frequently. So that seems like a urinary problem. So then it just makes me wonder, is there a GI-GU connection here? Now I see the burning word in my head was like ding, 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 like burning, yes. But again, it's not usually with urination. It's that upper epigastric pain. So all B, C, and D just don't seem closely related. The only one that really seems closely related is going to be the going to the dentist and needing 3 fillings. And this is a complication, because what can happen for, oh my Jesus, stop. What can happen for GERD and hiatal hernia is that they can end up having dental decay and needing a lot of support with their teeth. So a client with GERD or hiatal hernia is getting better if they have less pain, decreased symptoms like the burning, the reflux, and no signs of complications. But they're getting worse again if those things are getting worse, or if they have signs of a complication. The big ones are going to be aspiration. So just like with nausea, vomiting, we're worried because the tissue, the contents are going back, and they can aspirate either food contents into their lungs, which attracts bacteria and can lead to pneumonia, or they can get gastric acid or bile juices back into their lungs, and that can lead to breakdown of that tissue. We also worry about what's called Barrett's esophagus or esophagitis, which is tissue damage to the esophagus. And Barrett's esophagus is actually like a precancer. I'll talk about it a little bit more on the next slide, but can be very concerning. We talked about the dental decay, which, by the way, if I wasn't clear about it, A is the correct answer here. And then for the hernia, we're going to be worried about strangulation. I'll talk a little bit about strangulation here, but on the next slide, but we'll talk about it when we go over other hernias. So what kind of complications can happen with GERD and hiatal hernia? So with GERD, they can have esophagitis, which is an inflammation of the esophagus. And this is a result, of course, of the juices, stomach acids, and bile stuff moving backwards. And it can get to the point where it actually breaks down the tissue so much, it causes so much irritation that it can lead to cancer. Esophageal cancer is no joke. And so Barrett's esophagus is like a pre-cancer. And when people have Barrett's esophagus, it's kind of like a warning, like, hey, stuff is not going well. You're at risk for cancer. And so we definitely want to try to treat that. And so they have like endoscopic therapies that we can go in and we can help to clear up some of that, messed up tissue in the esophagus. We also worry about what's called strictures, and I'm going to talk about them on the next slide. But it's a blockage. It's a narrowing from the tissue gets really thick because it's really irritated. So think of like when you use a muscle over and over and over, it builds up and gets thicker to like prepare for whatever it is, trying to help you with. And so you definitely want to keep a close eye, and we'll talk about kind of some of the symptoms. The stricture can lead to a complete blockage where they're not able to get food into their stomach. We talked about aspiration already and the decay. Then, like I said, for hernia, they can have what's called strangulation. So this tissue that's usually below the diaphragm moves above the diaphragm. And what can happen is most of the time people have what's called a reducible hernia, which means it goes up above the diaphragm and then it can come back down. But what can happen with some patients is that they get what's called strangulation or an irreducible hernia, which means the tissue goes up and then it stays in place and it gets stuck. And in that place where it's slipped in that weak spot, and it actually can start to lose flow, like it can kind of almost literally strangle the tissue and cut off blood flow to the intestines, which can lead to death of that bowel, which is a very serious deal. And then hernia as well, they're at risk for aspiration. So real quick, going into stricture. So this is what a stricture looks like. The tissue builds up, and imagine this is your esophagus where food is supposed to be going down. So if you're trying to eat here, how is food going to pass through that? So it's like a narrowing or a tightening of the esophagus. And, I've had a patient once that had a really bad stricture, and she had some other GI stuff going on. It was so bad that the doctor couldn't even get like an endoscopy done because of it couldn't pass past the tissue. She had to go get a pediatric tube. It was a pretty big nightmare because there was maybe bleeding going on, and we couldn't even get to see if there was bleeding because of the strictures. So what do you call it? We're concerned, if food doesn't pass, if food gets stuck there, they can aspirate, they can end up vomiting a lot, but they also can't get the nutrients they need to be safe. So we usually do an endoscopy as we can get one, and then a barium swallow can also show us that there's that issue there. So they have to do, to treat it, they have to widen the esophagus. Pretty much they cut the extra tissue in order to treat that. So let's talk about medical treatments. So once again, I don't know, I feel like I've said so like 15 times, but I'm very sorry for that. But I think I'm the only one who notices these things. Like, it's kind of like when you do a presentation, you're like, oh my God, I said 50 times, which, by the way, I know I say a lot too. But anyway, as I just said it, but now I can't even listen to my own voice because now I've just said but 5 times. I'm like, I think I'm trying to find other words to replace the ones I'm saying over and over, but it's getting worse. Anyway, it's one of those things that you notice like yourself, but I don't think anyone else notices. So if this is like one of those, like if you watched How I Met Your Mother and it's like the break the glass thing where it's like you didn't notice that I did this and now you do, and now you can't watch my videos anymore, I don't blame you. There's lots of much better people out there that do not say and but and a lot of the same things, and I think they have better jokes. Maybe not, maybe no, I think I've got good jokes. I think my jokes are pretty good, but that's maybe all I've got going for me right now. Anyway, so there's more medications, which I know y'all love so much. So there is a handful of medications for GERD and hiatal hernia when it comes to treating their reflux, and we're going to go through these individually. So there's medications that are going to help decrease acid production. These are kind of like our maintenance meds, our daily meds, like PPIs or proton pump inhibitors or H2 receptor blockers. There's also medications we can use to coat the stomach and protect it from being so irritated from acid. Like sulcrafate. There's also things to decrease the amount of acid right now, like these top 2 are preventative, so I make less acid. This one helps to decrease the acid I have in my stomach right now. That's antacids. And then metoclopramide again, which can help to move things forward, so there's less acid chilling in the stomach. I want to teach them lifestyle changes, and teaching to manage their condition is going to be key. There are surgeries that can be done. You can kind of see up here in this picture. These are what are called a fundoplication. And what they do is they reinforce or help to get more closure of that lower esophageal sphincter. So think of it as kind of hugging that sphincter to help keep it more closed so there's less reflux. And for hernia, we can do what's called a herniophory, something like that. I'm probably saying that wrong, but it's like a hernia repair, where we can pretty much push that tissue back where it's supposed to be and then sew it so it can't slip through anymore. And then, like I talked about, there's endoscopic therapies where we can fix the tissue in the esophagus if it is not looking how we want it to look. So first, when we're talking about these meds, let's differentiate them based on their name. So you can remember PPIs. The PPIs all end, think of this, the prozole, the P in prozole. So all the PPIs end in prozole and they decrease your acid toll. So PPI prozoles. H2 receptor blockers all end tidine. If that helps you remember them, and antacids, a lot of them have M's like Maalox, Mylanta. All of them are going to usually have an electrolyte or a mineral in them. So when you see medications like aluminum, calcium carbonate, sodium meds, or magnesium hydroxide, things like that, those are going to be your antacids. So they usually have some sort of electrolyte in them. So that's for the names. And then let's talk about the difference in how these medications actually help. So like I mentioned, PPI and H2 receptor blockers decrease your actual starting acid production. So if you have a problem where you already have like acid backing up or too much acid, we don't want this acid to be building up over time. So this is like a maintenance or preventative meds. So these are going to help overall over time. I should have less attacks if I'm taking these regularly because I'm not going to be building up as much acid. So I'll know these worked because patients overall going to say, hey, I haven't had as many attacks. I haven't had as many issues. So that's a maintenance med. Then there's antacid. These are my rescue meds. So kind of think about long-acting, short-acting insulin or long-acting inhalers versus short-acting rescue inhalers. It's the same kind of concept where the maintenance helps to kind of maintain over time. So I don't need as much rescue, but we also sometimes need rescue meds. Sometimes there's certain foods, certain times where things get a little bit worse. So this helps right now to treat symptoms. And I will know it worked because they're going to say, hey, my symptoms are better. And this is like stuff like Tums, the chewable stuff that will work pretty quickly. They can treat it, but they cannot prevent it. And then if you're wondering why I'm going into this, it's important because this is going to tell you when you're going to take these medications. For PPI H2 receptor blockers, we take them daily at the same time. It's a maintenance. Whereas antacids, they're going to be best taken when symptoms are occurring. So usually they're considered most effective 1 to 3 hours after meals when the acid is present in the stomach. So let's talk about medication administration with these meds. For antacids, we do not antacids interact with a lot of meds, and you have to think how this makes sense. Antacids literally change the pH in your stomach, and all these meds, when they were made to deal with a normal pH in the stomach. So if I'm altering that pH, I'm altering how all meds are being absorbed. So I don't want to take any other meds 1 to 2 hours with in between antacids because they can be harmful or not work the way that they're supposed to or not be absorbed. Be careful with antacids and those with renal disease. People with renal disease don't do good with magnesium or aluminum products, and a lot of antacids are made from those. Sulcrophate, this is one I haven't talked about yet. So I talked about PPIs and H2 receptor blockers. You take those first thing in the morning usually, and like it talks about here, empty stomach, prior to your first meal, those are your maintenance. Then you take antacids 1 to 3 hours after a meal to treat. Sulcrophate is a little bit different in that it can help to, if you know you're about to eat something that's going to upset your stomach, if you know that your just acid levels are high, stuff like that, and you're struggling with it, you can take this before meals. So this is something to take on an empty stomach, and it coats. Kind of think of this like I'm about to have a lot of acid problems. I'm going to prepare for it. So it's coating the stomach so there's less pain and less breakdown of that tissue or issues with the tissue. So think your H2 receptor blockers, PPI, first thing in the morning. Sulcrophate before meals. Antacids 1 to 3 hours after meals. And that's kind of what you want to think about when you would want to give these. Like if I give sulcrafate after they've eaten, that's not going to help because it's meant to be there to coat the stomach when it's empty. And same the H2 receptor blockers, PPI, I can give those at any time of the day, but because it doesn't matter, it's a maintenance med, but it's best first thing to take it at the same time for consistency. And if I give those after a meal, it's not going to help them right now with their symptoms. The only thing that can help them right now is the antacids. So you always want to think the same, like some people will take antacids before a meal, but it's not going to be as effective as taking it 1 to 3 hours after the meal. So for PPI or the proton pump inhibitors, these are all of the prazoles. They have a lot of long-term side effects. They're not meant to be meant for long-term use. We try to use the minimal dose effective because they can lead to a higher chance of fractures, higher chance of kidney disease, vitamin and electrolyte imbalances, and even higher rates of dementia. So kind of just keep that in mind with these patients. Now, I know you're wondering, well, why don't we just use H2 receptor blockers for everything? For everyone, why would we even use these? Proton pump inhibitors are, they have a little bit better, they have similar, but a little bit better efficacy and stuff like that, or effectiveness. Yeah, as a whole, we just don't want to use them long-term. We'd prefer to use them for short-term use only. So what am I going to do as the nurse for these patients? Avoiding the spicy, fatty, acidic, and other GI irritants. And I have something on the next slide to help us practice that. Weight reduction is going to be helpful because it's going to help decrease some of that pressure, which is going to help to relax some of the strain on the lower esophageal sphincter and the pressure on the stomach that's leading to that reflux. Small, frequent meals and fluids between meals. So this is going to be a very big theme. There's, again, never a patient that we're like large meals. But especially with these GI disorders, small frequent meals, and then the fluids between meals, this is the same thing like bariatric surgery where I do not want them to get full on fluids. Aside from that, we want them to also sleep on an elevated pillow or like 4 to 6 inch block. Think like about 30 degrees. So this is a person who has an acid reflux pill, but we want them a little elevated because it's going to help. Because if you're laying flat, it's even harder if there's regurgitation. It's just easy, and it's easy for it to come up. My husband, he has the worst time with reflux, and he can't eat certain things like pizza and stuff close to bed. And there's been so many nights where like we'll go to bed and then he'll wake up a few hours later and it's just like straight up like crazy vomiting, and like he has the most disgusting vomit noise ever. Like I'm not saying anyone sounds cute when they vomit, but he sounds like Satan, like sometimes, like for real. And needless to say, sleeping elevated really helps. The other things is that not eating in general any foods within 3 hours of bedtime, which allows time for digestion. And then don't lie down for 2 to 3 hours after eating, like so during the day. And then just knowing your triggers and things like that, avoiding things that are triggers like alcohol, smoking, and caffeine also lowers your lower esophageal sphincter pressure. So let's talk about what is spicy, fatty, acidic. So let's go through these and see if we think they are in the spicy, fatty, acidic category. So first we have milk. So what do we think? I know you're probably thinking, you're like, well, you didn't say if it's like low fat or high fat, but in general, dairy is a pretty big GI irritant. So milk is in the spicy, fatty, acidic category. How about apples? Apples are actually bueno. Apples are a good food to eat. Fruits and vegetables and whole grains are good choices usually. Coffee is because it has caffeine. And then soda is a because it has caffeine. And then also the sugars and stuff like that can be dangerous, or not dangerous, but the sugars can be no, not detrimental. What's the word I'm looking for? The sugars can be irritating. There we go. Pears are good. So yes, we do like pears. They're not spicy, fatty, acidic. Whole grain bread. What did I say about whole grains? They are good. And we have chicken breasts. Chicken breasts are good. Chicken breasts are good for like everything. I don't know if there's anything that's like stay away from chicken breasts. There's a lot of stuff stay away from red meat, but chicken breasts seem to be muy bueno. Tomatoes are bad. So tomatoes, they have a very acidic quality. So we want to be super careful when it comes to tomatoes. And then what do you call it? Chocolate is bad. It's the chocolate specifically lowers your lower esophageal sphincter pressure, so we want to stay away from that. And melon is good. So most fruits are good. There are some that have more of an acidic quality, so you can definitely look those up. And I'm just hopefully not doubting myself with some of these foods, because now I'm going back and I'm like, maybe there was another fruit that you're not supposed to have. But I guess I'll have to make a, if there is one of these foods that I'm wrong about, I'm pretty sure apple, pears, and melons are all good and not acidic. But if for some reason I need to make a follow-up video, just look for that just in case. But I think I've got that down. So the big thing is fruits, vegetables, whole grains, chicken like breast, like low lean meats, things like that. And then avoid all the things that are tasty in life pretty much. But anyway, hope you enjoyed this video about GERD. See you for the next one.